How's it going, guys? We have a medium difficulty question for pathology, hepatobiliary, steps 1 and 2. 50-year-old woman, form with history of fatigue, itchiness of the trunk and back, yellowish discoloration of the eyes, serum cholesterol elevated. She had an episode of de Quervain subacute granulomatous thyroiditis 2 years ago. Vitals normal, pancreatic amylase lipase normal. What's most likely we see in this patient? Choice A, decreased biliary peristalsis. Wrong fucking answer. This would be biliary sludging that you can get if we had cholesterol stone cholelithiasis, classically during pregnancy as a result of progesterone, which slows biliary peristalsis. Okay, so mechanisms the USMLE wants for cholesterol stone increased proclivity in pregnancy. Estrogen upregulates HMG clay reductase. Progesterone slows biliary peristalsis. Wrong fucking answer. Choice B, increased cholesterol secretion to bile. Wrong fucking answer. Fat 40s female fertile. If we had cholelithiasis here, choledocholithiasis, which we don't have. Okay, the latter is stone in the biliary tree, cholelithiasis, stone in the gallbladder, but this is not cholesterol stone cholelithiasis. You could also know tangentially that ursodiol, aka ursodeoxycholic acid, which can sometimes be given to patients who have stones. The mechanism USMLE wants for that drug is decreases cholesterol secretion into bile. Choice B, wrong fucking answer. Choice C, oxalate urothiasis, wrong fucking answer. So sort of just a miscellaneous distractor. If you're not sure what's going on, you might edge toward it. You could know that Crohn's disease, there's increased risk of oxalate urolithiasis. Okay, malabsorption, fat soluble vitamins, different nutrients with Crohn, increased fat in the small bowel lumen, increased chelation with calcium, intraluminal saponification, more oxalate is available for absorption if less is going to bind to calcium in the bowel, and then you can get stones that way. Wrong fucking answer. Choice D, production antibodies against organelle protein. Abstruse, obscure answer. Choice correct answer. Primary biliary cirrhosis. You get anti-mitochondrial antibodies. Okay, and literally, if you look it up, anti-mitochondrial antibodies are antibodies against mitochondrial proteins. Holy shit. Okay, this is a very buzzy, easy presentation. If you've been following my content, you'll know this is as bread and butter as it gets. You have a woman, 20s to 50s, high cholesterol, generalized pruritus, high ALP, high bilirubin, and they like giving a history of autoimmune disease either in her or a family member. Okay, they'll say the brother has rheumatoid arthritis. She has history of thyroiditis or type 1 diabetes. The caveat is if they tell you history of IBD, UC, that's more likely to be primary sclerosing cholangitis, okay, high yield extraintestinal manifestation of UC. But just in general, this presentation, very buzzy for PBC. You got to know that. Okay, that's actually pass level for USMLE, the PBC diagnosis, and then this answer choice a little bit more obscure. Okay, you can actually give ursodeoxycholic acid ursodiol for this patient, which, as we said, decreases cholesterol secretion to bile. Let's just whip through the final answer and the relevance of the pancreatic enzymes being normal. It just 100% eliminates gallstone pancreatitis as a diagnosis. Okay, so also, when you see jaundice in a patient with normal pancreatic enzymes, you do want to be thinking of things such as choledocholithiasis, where the stone's higher up, not causing gallstone pancreatitis. But the history of autoimmune disease, PBC is more likely, as well as pancreatic cancer. You got to be thinking of head of pancreas cancer can impinge on the common bile duct and cause jaundice. Okay, Courvoisier sign, painless palpable gallbladder in an afebrile patient who's jaundice. Once again, the autoimmune disease here. Very, very, very buzzy presentation. Okay, so let's just whip to the final one. Sphincter vodi dysfunction, wrong fucking answer. This will show up as a wrong answer on USMLE. I don't think I've ever seen it as a correct answer. Okay, but in theory, this could present similarly to gallstone pancreatitis, where pancreatic enzymes are elevated, high ALP, high direct bilirubin, but the patient doesn't have a gallbladder, had a remote history of cholecystectomy. Okay, where there's no chance that it's a stone. So it'd be a diagnosis of exclusion on USMLE, meaning you would eliminate to get there, and theoretically it could be an answer. But as I said, I've only seen it as a wrong answer. In this case, wrong fucking answer. You know the deal. On team, make more content, subscribe. Appreciate your time. That's it.